Okay, I think we'll go ahead and get started. Again, I would like to welcome you to our update today on the Critical Access Hospital PEPR. My name is Kim Rahor. I work with TMF Health Quality Institute, which is contracted with the Centers for Medicare and Medicaid Services, or CMS, to develop, produce, and disseminate the PEPR for critical access hospitals. And today I'm going to be focusing on the most recent release, the newest release of the PEPR. Today, I plan to review the revisions in the Critical Access Hospital PEPR that you'll find in the most recent release, which are primarily focused on the 1- and 2-day stay target areas, and I'll review those in more detail in just a moment. I also will be reviewing other resources that are available for you, and I'll talk a little bit about the peer group bar charts, which are have not yet been developed for critical access hospitals, but we have plans to do so. So I'll go into more detail on that item as well. If after today's session you're feeling a little lost, perhaps PEPR is new to you, I would encourage you to go learn more about the PEPR using the training and resources materials on our website. I have just completed recording a new set of training sessions. They are available as 10 different chapters that you can access at your leisure. They're a little bit shorter than the segments that I had out there previously. They're a little bit more focused on the individual information that you might be interested in. So I would encourage you to visit our website, go to the Training and Resources page, and check out the new resources that we have out there. So what is PEPR? PEPR is an acronym that stands for Program for Evaluating Payment Patterns Electronic Report. And essentially, the PEPR is a comparative data report that summarizes one hospital's Medicare claims data statistics for areas that have been identified as at higher risk for improper Medicare payment. And we call those target areas in the PEPR. In the PEPR, what we're doing is we're comparing your Medicare claims data statistics with aggregate data for other hospitals in 3 different comparison groups: all hospitals in the nation, all hospitals in the Medicare Administrative Contractor or MAC jurisdiction, and then all hospitals in the state. These comparisons can help give us an idea of how different our statistics are from the majority of other hospitals, and that could be the first clue as to whether or not there might be something we need to be concerned with. I also want to stress that the PEPR cannot identify improper Medicare payments. Those can only be confirmed through a review of the medical record, the documentation, comparing that with the information that was submitted on the claim. So remember, the PEPR is simply a comparative data report summarizing your claims data, and it cannot identify the presence of improper Medicare payments. So PEPR has been around for a number of years. Originally, it was developed in 2003 for short-term acute care hospitals, and a year or two later for long-term acute care hospitals. At that time, it was provided through the State Quality Improvement Organization. In 2008, the QIO program was changed, and so the PEPR actually was not available for about a year in between these contracts. In late 2009, TMF was contracted directly with CMS through the Center for Program Integrity Provider Compliance Group, and our responsibility at that time and moving forward was to develop and produce the PEPRs for all hospitals in the nation. So starting in 2010, we were developing the PEPRs once again for short and long-term acute care hospitals, and over the past few years, you can see we've developed additional types of PEPR for other providers. And the Critical Access Hospital was actually the first new type of PEPR that we developed back in 2011. So why does CMS feel that the provision of PEPR to providers is helpful? CMS is mandated by law to protect the Medicare Trust Fund from fraud, waste, and abuse, and they use a number of strategies to meet this goal, such as provider education, early detection through medical review, which might be conducted by the Medicare administrative contractors, recovery auditors, or other federal contractors, as well as data analysis activities. The provision of PEPR to hospitals supports these strategies. CMS considers the PEPR to be an educational tool that can help providers identify where they might be at a higher risk for improper payment so that then they can proactively monitor and take preventive measures if necessary. I might also mention that the Office of Inspector General, or OIG, encourages providers to have a compliance program in place to help protect their operations from fraud and abuse. An important component of a compliance program is conducting regular audits to ensure that charges for Medicare services are correctly documented and billed, and that those services are reasonable and necessary. The PEPR supports the auditing and monitoring component of a compliance program. So let's now move on to focusing on the newest PEPR for critical access hospitals, which is the version Q4 FY16, or through the fourth quarter of fiscal year 16. The Critical Access Hospital PEPR was made available April the 14th of this year, and it summarizes statistics for 3 federal fiscal years, 2014, 2015, and 2016. Now, each time we create or generate a PEPR, we refresh the statistics for all of the time periods included in that release. So that means we go back to the paid claims database and we download a new set of Medicare claims data for all of the hospitals for all of the time periods. And so if you're looking at your PEPR, your newest PEPR, and comparing it to last year's release, you might notice that there may be some slight differences in numerator or denominator counts. That would occur because there are perhaps late claims that may be submitted to your MAC for reimbursement, claims adjustments, or those types of things. So remember that when you're looking at your PEPR, all of the statistics have been refreshed for this new release. And of course, we do roll off the oldest time period as we add the newest one on. So let's move on now to talk about the improper payment risks for critical access hospitals. Again, remember, the PEPR cannot identify improper payments, but the target areas are focused really on the areas that could be at risk for critical access hospitals. Now, because critical access hospitals treat many of the same types of patients and provide many of the same services as short-term acute care hospitals, the PEPR for critical access hospitals includes many of the same target areas. The primary difference is that critical access hospitals are reimbursed based on cost rather than prospectively through the Inpatient Prospective Payment System, DRG system model. Also, critical access hospitals tend to have a shorter length of stay because they're limited to an overall average length of stay of 96 hours. Now, with all that being said, critical access hospitals are still at risk for medically unnecessary admissions. And although DRG coding errors don't impact the critical access hospital's reimbursement, correct coding is still important, and that's why we have continued to include these target areas, the ones that are focused on coding-related issues, in the PEPR. So those of you who are familiar with PEPR recognize that we calculate the statistic for each of these areas using a numerator and a denominator. In the numerator, the discharges, we're identifying the discharges that are potentially problematic, those that may be miscoded or admitted unnecessarily. And then in the denominator, that's the larger reference group that also includes the numerator. We have 2 different types of target areas in the PEPR. Those that are focused on coding-related issues, so that would be the potential for overcoding or the potential for undercoding, as well as those that are more related to admission necessity. On this slide, I have listed all of the target areas that are currently in the critical access hospital PEPR. And I've listed in red those target areas that have had a modification for this particular release. The single CC or MCC target area, most of you probably won't even notice any change in your statistics. There was a slight revision here to make this target area now evaluate those ICD-10 principal diagnosis codes that are their own CC or MCC, as identified in Table 6K of the IPPS final rule. So that was a small change that was made there. More noticeable are the changes that we made to the short stay target areas, the 2-day stays and the 1-day stays for medical and surgical DRGs target areas. So I'm going to focus on these a little bit more closely in these next couple of slides. We have a couple of target areas that are focused on 2-day stays in the Critical Access Hospital PEPR. One is looking at 2-day stays for medical DRGs, and the other is looking at 2-day stays for surgical DRGs. Starting with this release, we are excluding from both the numerator and the denominator claims with a current span code 72, where there's a through date on the day of or the day prior to the inpatient admission. A current span code 72 identifies when there are outpatient services that are associated with an inpatient admission. And the reason that we are excluding the claims with a current span code is to more focus truly on those admissions that are truly 1 or 2-day stays. When patients receive services at the hospital before they're admitted as an inpatient, it's possible that those services may span 1 or 2 additional nights. And those admissions then would qualify or would meet the 2-midnight rule that CMS established a few years ago. And so our focus here is on trying to make these statistics more accurately reflect the true discharges that are 2-day stays and that are 1-day stays. So you'll see we made this exclusion for the 2-day stay target areas as well as for both of the 1-day stay target areas. In the case you're wondering what the impact might be on your PEPR statistics, we did take a look at how this exclusion would affect the target area statistics. For most of these target areas, most providers' target area percent did not change. However, there are also a fair amount of providers whose target area percent either increased or decreased. So it's likely that when you're looking at your target area statistics, you'll see some changes there from a last release to this new release because of this new exclusion. Now I'd like to move on to reviewing how we calculate percentiles. So each of our target areas, as you may know, we have a numerator and a denominator, and we use the numerator and denominator to calculate a target area percent. We also use percentiles in the PEPR to identify when the provider's target area percent is different from most of the other hospitals in the comparison group. And since percent and percentile are easily confused, I thought I would just spend a few minutes today helping to review this concept of percent versus percentiles. When we calculate percentiles in the PEPR, what we do is we take the target area percent for a particular target area for all of the hospitals in the group. So let's just say all the hospitals in the nation, and maybe this is for septicemia. We take those target area percents and we sort them from highest to lowest. As you can see, we have the ladder here. In each rung of the ladder, we have an associated target area percent. We identify the target area percent below which 80% of the other providers fall. And that target area percent is identified as the 80th percentile. Now remember, in the PEPR, we identify as what we call high outliers any providers whose target area percent is at or above the national 80th percentile. And those are the providers who are considered to be high outliers. For the coding-focused target areas, we also identify low outliers. Those would be the providers whose percent is at or below the national 20th percentile. The 20th percentile represents the point below which 20% of the hospital's target area percent fall. So essentially, we're identifying the providers in the top 20% as high outliers, the providers in the bottom 20% as low outliers. And in the PEPR, you'll see when your provider, when you are at or above the national 80th or at or below the national 20th, you'll see your target area percent color-coded in either red bold print or green italics. And these are the boundaries that we use to identify outlier status. I think it would be a good time for me now to move into a sample PEPR where we can continue this discussion about percents and percentiles and help give you a better foundation for that. So what we're looking at here is a sample PEPR for a critical access hospital. Remember, the PEPR is distributed as a Microsoft Excel workbook. You would navigate within the PEPR by clicking on these worksheet tabs along the bottom of the screen. When you first open your PEPR, it will open to this tab that's labeled Purpose. It will identify for you the most recent quarter of statistics that are summarized in your report. So this one is through the fourth quarter of fiscal year 2016. Here you would see your provider number or your CMS certification number as well as your provider name. Here is the version, which is always the same as the most recent quarter of statistics summarized in that report. And here you would see your MAC jurisdiction. The jurisdiction comparison group is comprised of all of those hospitals that submit their claims to one of the individual MACs. And there are 12 Medicare administrative contractors that process claims for critical access hospitals. And so the MAC jurisdiction comparison group basically summarizes the claims data for all of those hospitals that submit their claims to each of those individual MACs. And so if you're thinking about what is the jurisdiction comparison group, it's all the hospitals that submit their claims to that same MAC. Moving on, we can see on the definitions tab here we have included the numerator and denominator definitions for each of the target areas that are included in the PEPR. This might be helpful if you're looking at your target area statistics and you're trying to figure out, well, what does this numerator count represent? What does the denominator count represent? You can come to the definitions worksheet and see exactly what makes up that numerator. The next report is called the Compare Targets Report. And I like to refer to this report as the heart of the PEPR. It is the only place within the PEPR that you can see all of the statistics for your hospital, for the target areas, all on one report. It is limited to the most recent fiscal year, so all that this is representing is fiscal year 2016. And also the target areas that are included on this report are only those for which your hospital has sufficient data to generate the statistics. We have to have a numerator count of at least 11 in order to calculate statistics for a target area and a time period. In the report, you'll see the target area name, a brief description of the target area numerator and denominator, the number of target or numerator discharges, then we see the target area percent. The target area percent is calculated by dividing the numerator discharges by the denominator discharges, which are not on this report, but I'll show you where you can find that in just a bit, and then multiplying by 100. That gives us the target area percent. Here we identify the hospital's national percentile, the jurisdiction percentile, and the state percentile. And the last column identifies the total amount of Medicare reimbursement that the hospital received for the numerator discharges. So if we take a look at the first target area, stroke intracranial hemorrhage, we see that this hospital had 18 discharges that met the numerator definition. The target area percent that's been calculated is 75.0. So that's the target area percent. Now think about the ladder. example that we just left on the slide before. Remember, we take these target area percent for all of the hospitals in each of these three comparison groups, and we sort them from highest to lowest. The national percentile identifies the percent of hospitals in the nation that have a lower target area percent. So 17.9% of hospitals in the nation have a lower target area percent than this hospital does. So because this hospital is below the national 20th percentile, their target area percent is color-coded in green italics, meaning that they're a low outlier and that they could be at risk for undercoding. So the national percentile identifies how the hospital's target area percent compares to all of those other ones in the nation for this particular target area. When we're compared to all the hospitals in the jurisdiction, 21.7% of them have a lower target area percent than our hospital does. And you can see here the state percentile is empty. This will occur when there are not enough hospitals in the state to calculate percentiles. If there are fewer than 11 hospitals in the state that have sufficient data for the target area, then the percentiles will not be calculated and you will see a blank cell such as this. And then we can see that this hospital received $157,537 in Medicare reimbursement for these 18 discharges. Let's look at a few other examples. We can see here this hospital is actually a low outlier for several of these coding-focused target areas. If the hospital is not an outlier, if their target area percent is not at or above the national 80th percentile, or is not at or below the 20th percentile for these coding-focused target areas, then you'll see the target area percent just printed in regular black font. Here's the target area for which this hospital is a high outlier. The 30-day readmissions to same, a numerator count of 76, the target area percent was 11.2%. When compared to all of the hospitals in the nation, 82.8% of the hospitals in the nation have a lower target area percent. So again, thinking about that ladder, we're up near the top, in the top 20%, and so that gives you some context, helps you think about how your target area percent falls within that distribution. As compared to the jurisdiction, 74.4% of the hospitals have a lower target area percent, and as compared to the state, 91.7% of the hospitals have a lower target area percent. Moving on now to look at each of the individual target area reports, and I won't cover them all because there are a fair number, but once you get used to looking at these target area reports, I think you'll find it pretty handy. They're all formatted in the same way. In the graph for each target area, we graph as the blue bars here the hospital's target area percent for each of the 3 time periods. And this is a nice way to look to see if your target area percent might be changing over time. And you can also see how your target area percent compares to the 80th percentile and the 20th percentile. We include on the graph the trend line for the national 80th percentile, which is the solid line. The dashed 80th or the dashed red line is the jurisdiction 80th percentile, and I think that for this target area, the state is not calculated. It looks like there's 0 here. Similarly, for the 20th percentile, this is nation and jurisdiction. So you can see how the target area percent compares to those those percentiles. Below the graph, we include, or I display your target area percent for each of the 3 time periods. And you'll see here that since the hospital is below the national 20th percentile, their target area percent is green italic. Here is the numerator count, and here's the denominator count. We also calculate the average length of stay for the numerator discharges, the average length of stay for the denominator discharges, the average amount of Medicare reimbursement for these numerator discharges, as well as the total amount of Medicare reimbursement for these numerator discharges. So these are really the numbers behind these statistics in the graph. Below the hospital data table, we have this comparative data table, which identifies the target area percent that is at the national 80th percentile, the jurisdiction 80th percentile, and the state 80th percentile, as well as the target area percent that is at the national 20th percentile, the jurisdiction 20th percentile, and the state 20th percentile. So remember, the latter example, we identified the points, the target area percents that were at the 80th and at the 20th percentiles, and that's where you can find this information. And below the comparative data on all of these target area reports, we include what we call suggested intervention. So if the hospital was a high outlier, we have a brief description here of what that could possibly represent and perhaps what the hospital might consider auditing if they were going to take a closer look. Similarly, for low outliers, we have suggested intervention. What does it possibly mean if you're a low outlier, and what possibly steps might you take as far as looking at medical records? I'm going to go back to the Compare Targets report. I remember there was something else I forgot to mention while I was reviewing these statistics. So on the Compare Targets report, we identify the exact percentiles for your hospital. And this is the only place that you will see your percentiles in the PEPR. So if you're looking at the target area statistics for a given target area, you will not see your percentiles here. Your percentiles are only on the Compare Targets report, and these percents represent the 80th percentile for these various comparison groups. So I'm clicking on the next worksheet tab, which is for respiratory infections. And this particular hospital does not have any reportable data, a numerator count of at least 11, for this target area for any of the time periods. And so if you open up your PEPR and if you're going through your reports and you see one that looks empty like this, the reason is because your hospital doesn't have sufficient data to generate statistics for that target area. And so in that instance, there won't be any blue bars on the graph, and the data table will be empty. And you can see that for this particular target area, we only have the national 80th and 20th percentiles that are calculated. So that just tells us that there are not a lot of hospitals in the jurisdiction or the state that have reportable data for those target areas, for this target area. So I'll click through a few of these target area reports, see if there's anything that pops out at us. I might want to mention, for medical DRGs with a CC or an MCC and surgical DRGs with a CC or an MCC, I suggest that hospitals look at these two target areas in tandem. You might expect this particular hospital has a slight decrease over time in the medical DRGs with CC or MCC, while if you look at their surgical DRGs with a CC or an MCC, they're slightly increasing. And sometimes when I'm looking at PEPRs for various providers, if there is a great difference between the medical DRGs and the surgical DRGs, it makes me wonder if perhaps There is a difference in the patient population for their medical patients versus their surgical patients. Perhaps one group is more or less compromised or has more complications and comorbidities. It also crosses my mind that it's a possibility that there is a difference in the way the documentation is entered in the medical record for the physicians that treat the medical patients versus the physicians that treat the surgical patients. And so when you're looking at your statistics, it's important to ask yourself if what you're seeing in the PEPR makes sense to you given what you know about your patient population, your physicians, your medical staff, your specialty services, those types of things. And if something doesn't look right, then it's always a good idea to take a closer look. This is single CC or MCC. This target area, 3-day stay, 3-day skilled nursing facility admissions is also in the short-term reports, but it's intended to look at instances where there was a 3-day stay and the patient goes to a skilled nursing facility after discharge. Swing bed transfers is a target area that is specific to critical access hospitals. This is not in the short-term acute care PEPR, and it's also developed to monitor a similar concern. Admissions to qualify for a SNF or a swing bed admission. And we're getting into the 2-day stays. These are the short stay target areas. 1-day stays for surgical. Something else that I didn't mention while we were talking about the comparing the surgical and medical DRGs. When you're looking at your statistics, and this is going to build off of some of the comments that I just shared, if you see unusual increases or decreases in your target area statistics, that's another opportunity to ask yourself what possibly could be behind those changes. And I know I mentioned some of the patient population, but think about it in a larger sense of the word, because there could be perhaps openings or closings of other healthcare providers within your community that have changed your patient population. It's possible that there have been some changes in the way that you conduct your admission necessity reviews, or maybe your health information management, your coding staff have changed, and that might be reflected in your statistics. Have there been changes in the folks who are submitting your claims to Medicare? Maybe things are different now, and that's something to consider. If you've embarked upon documentation improvement programs, that's another factor that could change your statistics. So think about what might be behind changes in your PEPR statistics. And I always encourage providers that if something doesn't seem right, if it doesn't reflect what they expect to see, then it's important to follow up and take a closer look at some medical records, get together with others within your organization, and just make sure that everything is being handled properly. Last, I'll cover a couple of supplemental reports that are included in the Critical Access Hospital PEPR, and these are supplemental. They don't have any impact on your risk for improper Medicare payments. They're simply to help you with information about your hospital. We're identifying the top DRGs for the most recent 4 quarters. That would be for the most recent fiscal year. And we're identifying by total number of discharges for each of these DRGs. So you'll see the DRG number, the DRG description, the total number of discharges for that DRG that occurred in the most recent fiscal year, the proportion of discharges for each DRG to total, and your hospital's average length of stay for that DRG. This report will include up to 20 DRGs. It is possible that there may not be 20 listed on your report. That would occur if there were DRGs that had fewer than 11 discharges in the most recent fiscal year. In that case, we are not able to display statistics for those DRGs. At the bottom of the report, we have some summary statistics for the top DRGs as well as for all. And we also have a similar report that is aggregated at the jurisdiction level that includes the same type of information for the top DRGs in the jurisdiction. We have the jurisdiction average length of stay as well as the national average length of stay included. So that's a quick look at a sample pepper. I'll go back to my presentation now and move along. Now sometimes providers will ask me, so do I have to use my pepper? Am I required to take any action as a result of the statistics in my pepper? What do I need to do? The answer is no, you don't have to use your pepper. There is no required action that you need to take in response. You don't need to write up a report or send anything to us. The pepper is simply a way to give you a heads up, let you know how your statistics compare to those to the other hospitals in the nation, jurisdiction, and state. I would prefer that you think about the pepper as a roadmap. It's there to help you identify potentially vulnerable or improper payments. And the other thing that I'd like to mention is that there are other contractors, the MACs, the recovery auditors, and so on, who are looking at the Medicare claims data as well. And they may be conducting similar comparisons to what's reflected in your pepper. So it might be a good idea to just to have a heads up how your statistics look. And that way you can be aware of the fact that your provider looks different from most others, and you can have the opportunity to ask yourself why, to dig a little deeper if there's something that needs to be concerned about, and you'll just be one step ahead if you do have a request for some medical records by one of these other contractors. How do you get your pepper? The Critical Access Hospital pepper is distributed electronically through QualityNet. QualityNet is a secure distribution system that's been developed by CMS primarily for the reporting of hospital quality data. And so we use this system to distribute the peppers. The hospital's QualityNet administrator is probably the person who is involved in reporting the hospital quality data to CMS. But there also can be others within the organization who have QualityNet accounts. If you would like to get a QualityNet account, you would just simply coordinate with your hospital's QualityNet administrator to have them set up an account for you, a basic user account with the pepper recipient role. We do upload the peppers electronically, and once they're uploaded, they are available in QualityNet for 60 days, after which all of the files are purged from the system. So we do encourage you to download your pepper as soon as it's released. If you miss that time frame, if by the time you get to QualityNet or by the time your account, or if you get a new account, a new QualityNet account, and you'd like to receive the pepper, you can request that we upload it, and we can do that. Just submit a request for that through our help desk. Once you finally have your pepper, if you do see that there's a lot of red or a lot of green, the first thing I would stress is that you not panic about the statistics in your pepper. Just because you're an outlier, high or low, it doesn't mean that you're doing anything wrong. It doesn't mean that any compliance issues exist. But again, think about what factors are leading to your outlier status, and ask yourself if you expect to see what you do there. If you feel that something isn't looking right, we always encourage you to take a closer look at some medical records. I might also say that remember that by default, the top 20% of providers and the bottom 20% of providers for the coding-related target areas are always going to be identified as outliers. And so, again, just remember, this outlier status does not mean that you're doing anything wrong. This means that you're in the top 20% or in the bottom 20% as compared to all the other hospitals. Some other resources that you might find helpful, we have made available on the data page at pepperresources.org national level and state level data for the target areas as well as for the top DRGs. And these are updated following each report release. They have been updated for this release, and so if you go to pepperresources.org, to the data page, there is a section there for critical access hospitals, and you can find those resources there. Also, and I mentioned this briefly at the beginning of the session today, we have made available for a number of other provider types peer group bar charts. And the peer group bar charts are going to be developed for critical access hospitals as well. They're just in the works right now. And they'll be made available on the data tab as well. I plan to send out a notice when those are available. Might be a few months. The nice thing about the peer group bar charts is it will calculate or identify for you the target area percent that is at the 80th, 50th, and 20th percentile for each of the target areas for a number of different characteristics. And so we would be looking at location, which would be urban versus rural. We'll be looking at ownership type, so for-profit or physician-owned versus nonprofit or church-owned versus government. And we'll also be looking at size, number of discharges on an annual basis, a simple stratification, bottom third, middle third, top third. And so this would give you another way to compare your hospital to a group it might consider to be its peers. And so we'll be working on that over the next few months, and I'll be sending out information once those are ready. I also thought I would mention today the impact of ICD-10 on the statistics in your PEPR. Remember, ICD-10 went into effect for fiscal year 2016, and so we have been looking at the impact on the short-term acute care hospital target areas for about a year now. And I thought that I would highlight a few of the target areas related to critical access hospitals where you might see a difference. In general, for the short-term acute care hospital reports, we saw a greater impact for target areas that were related to procedures or surgical DRGs. In general, we saw the claim counts for those increase. And similarly, in critical access hospitals, we have the same similar findings. Of course, if you have questions about coding, so you would need to refer to the official coding guidelines and coding clinic. I have included here on a few of these slides some of the high-level information. So for respiratory infections, for example, you can see not really much change in the numerator, but we had a decrease in the denominator. So the proportion, the target, this is at a national level, the national average did increase for this particular target area. And this was follows a similar pattern to what we saw in the short-term acute care hospital arena. For simple pneumonia, we had numerator and denominator decrease, just as in short-term acute care hospitals. That resulted in a small increase in the target area percent at a national level. Surgical DRGs with a CC or MCC, we see increases here for numerator as well as for denominator. The overall proportion did not change significantly. 2-day stays for surgical DRGs, there was an increase, fairly significant one in the numerator, a smaller increase in the denominator, for a fairly significant increase in the overall average, the overall proportion. And 1-day stays for surgical DRGs, also increases there. So do keep these changes, these national level changes in mind. You may see similar reflections in your PEPR as you are looking at your hospital statistics. I wanted to just review, there are a number of resources that are available on the Training and Resources page. There is a PEPR User's Guide for the Critical Access Hospital PEPR. You can also find a jurisdiction spreadsheet that identifies for each of the 12 MAC jurisdictions the total number of hospitals for that jurisdiction in total and also broken out by state. There are the recorded training sessions that I mentioned earlier. There is a sample PEPR on the Training and Resources page. And if you're interested in the other types of PEPRs for the other provider types, you'll find the sample PEPR for those providers on the respective Training and Resources page. And there's also a document out there that records the history of target area changes and the impact that might be seen on the statistics. If you have questions about your PEPR or if you need assistance obtaining your PEPR, please contact us through our help desk at pepperresources.org. There's a form that you'll fill out, and once you submit it, a member of our team will respond promptly to assist you. I do ask that you not contact other associations or organizations with questions about PEPR. We are the official source of information, and we want to make sure that your question is answered correctly. So please do contact us if you have questions or need assistance. And this is just a look at our pepperresources.org website. This is the home page. I have circled for you the section for critical access hospitals. You can get to the resources easily from our home page. And if you haven't joined our email list, there's a Join Now button where you can join to get information about future releases, training opportunities, and so on.